Now we will start the next session. Workshop 7, Systemic Chemotherapy and Oncology 3. The chairs are Dr. Tawasak Tamwandi, Dr. Yosuke Nakai, Dr. Motoyuki Otsuka, and Dr. Kaoru Tsuchiya. Doctors, please.
Welcome to this workshop 7, System Chemotherapy and Oncology 3. So this session will be chaired by Dr. Tsuchiya and Dr. Otsuka, and Dr. Tamandi and Dr. Nakai are online. So in this workshop, so-called real-world data about medical therapeutics against advanced SCC will be provided. I hope this information will be useful for your clinical activities. So the first, let's go to the first speaker, please.
Okay, the first speaker is Dr. Kazufumi Kobayashi from Chiba University. His title is Prospective Study to Assess the Safety and Efficacy of Ramucirumab in Advanced ACC in Japanese Real-World Practice Revolution Study. Please start.
Thank you for the introduction. Good morning, everyone. I'm Kazufumi Kobayashi from Department of Gastroenterology at Chiba University. It's a great honor to be able to speak to you here. Now I'd like to talk about a prospective study to assess the safety and efficacy of ramucirumab in advanced hepatocellular carcinoma patients in Japanese real-world practice revolution study. Let me start the presentation. This is COI. As you know, systemic therapy for advanced HCC has been making remarkable progress. So far, 8 regimens has been approved for use in the standard of care of patients with advanced HCC. Sequential treatment with several drugs is increasingly becoming a mainstream treatment strategy. We focused on ramucirumab among these drugs and conducted this study. Ramucirumab has demonstrated a significant extension in overall survival compared to placebo as a second-line treatment after sorafenib in REACH2 study. However, in actual clinical practice, ramucirumab used not only after sorafenib, but also in various treatment regimens, like after lenvatinib or atezolizumab plus bevacizumab combination therapy. What about the safety and efficacy of ramucirumab in real-world clinical practice? The aim of this study is to assess the safety and efficacy of ramucirumab in the current setting of systemic therapy for advanced HCC. This slide showed the study settings. This was a multi-center prospective non-randomized single-arm study at 13 institutions in Japan. Primary endpoint was progression-free survival rate 6 months after the initiation of ramucirumab. Secondary endpoint were overall survival, progression-free survival, time to progression, and discontinuation rate due to adverse events. Eligible patients were those who treated with ramucirumab as second-line therapy after lenvatinib or atezolizumab plus bevacizumab, or third-line therapy after atezolizumab plus bevacizumab, followed by lenvatinib. Other inclusion criteria were patient with Child-Pugh and alpha fetoprotein 400 or higher. Here is the patient enrollment flow and patient characteristics. 19 patients consented to the study, and 2 patients were excluded. Therefore, 17 patients received ramucirumab in the study. of 70 patients who participated in this study, the median age was 73, and 14 patients were male. 11 patients showed Child-Pugh score of 6, and the remaining 6 patients showed a score of 5. 7 patients received ramucirumab after the lenvatinib, and 7 patients after atezolizumab plus bevacizumab, and 3 patients after atezolizumab plus bevacizumab followed by lenvatinib. Now I'd like to show you the result of prognostic analysis. In 17 patients who received ramucirumab in this study, median overall survival were 12.0 months. Median progression-free survival was 30.7 months, and 6 months PFS rate was 14.3%. These results were considered comparable to those of REACH2 study. This slide shows the swimmer plot of treatment duration and the best response. Unfortunately, among the patients who participated in this study, there were no cases of complete recession and or partial response. The color of the birds indicates difference in prior treatment. There were no clear difference in treatment duration according to prior treatments. Next, this figure shows the best % change in target lesions. The upper part of the baseline represents the tumor enlargement, and the lower part represents the tumor reduction. The changes in the target lesion during the treatment period were generally within 20%. There's no clear difference in changes in the target lesions according to the prior treatments. Here you can see the incidence rates of adverse events. This figure depicts adverse events observed with a frequency of 10% or higher. Frequently occurred adverse events were hypertension, decreased appetite, fatigue, hypoalbuminemia, and proteinuria. Discontinuation rate due to adverse events were 29.4%. This graph represents the changes in the liver function result before and after the treatment with ramucirumab. In some patients, the LV score has gotten worse, while there were also cases showing improvement, and no consistent trend was observed. This pie chart on the right of the slide represents the breakdowns of the subsequent treatment after ramucirumab. Over 50% of patients were able to receive the next line systemic therapy. In total, transition to the next treatment was possible in 76.5% of patients. This is the last slide. Ramucirumab demonstrated comparable efficacy when used after lenvatinib or atezolizumab plus bevacizumab compared to after sorafenib. Although the incidence of adverse events were higher than in the REACH2 trial, ramucirumab could demonstrate sufficient safety when managed appropriately. The present study was supported by many collaborators. I'd like to express the greatest appreciation to my coworkers. Thank you for your attention.
Thank you. Thank you so much. Your nice presentation. The paper is now open to the discussion. Are there any comments and questions from audience? So,
Hi.
good morning, Professor Tawande.
Yes. Good morning. Very nice study. And may I ask if I cannot remember correctly, have you presented the levels of AP at the time of recruiting the patient into the study? The levels of alpha fetoprotein,
Alpha fetoprotein.
right?
All patients showed alpha fetoprotein 400 or higher.
400 and you mean at the time of the recruiting the patient into this study, right?
It's one of the inclusion criteria. Yeah.
And since there were just 17 cases in this study, when you present the survival curve, it's going to be quite, I think, misleading. By the way, how many patients can survive beyond 1 year?
I'm sorry, I don't have the correct data because almost patients received the next line therapy now. So sorry, I don't show the number of patients who died.
Thank you.
I'm sorry, thank you.
So, any other questions? May I ask a question?
Yeah.
Were there any differences between the patient after atezolizumab or after lenvatinib? Because when we use TKIs, after checkpoint inhibitors, some patients revealed a better response after checkpoint inhibitors. Were there any difference?
Thank you for your question. Of course, the number is small because of the difficulties to enroll this study. We tried to explore any differences according to the prior treatment. But I think there are no clear differences in our analysis after the lenvatinib or atezolizumab plus bevacizumab.
Thank you. Thank you. Thank you for your presentation.
Thank you so much.
So next speaker is Dr. Keisuke Koroki from Chiba University. His title is a randomized phase 2 trial to assess safety and efficacy of regorafenib in patients with advanced HCC who are not included in the RESTORE trial, REGAIN trial. Please start.
Thank you for introducing me, Chairperson. Good morning, everyone. My name is Keisuke Koroki. I'm from Chiba University, Japan. Today, I'd like to talk about the result of REGAIN trial, which assess regorafenib in advanced HCC patients who are not included in the RESOURCE trial. Let me start the presentation. The COI is as shown in the slide. This slide shows the approved 8 regimens of systemic therapy in HCC in Japan. This orange line has evidence of sequential therapy from randomized control phase 3 trials. The second line drugs were developed based on the premise that the sorafenib was the first line treatment. As for regorafenib, the RESOURCE trial was the basis for approval. In the RESOURCE trial, only patients who tolerated sorafenib 400 mg per day or more and progressed on sorafenib were enrolled. However, in clinical practice, sorafenib is often reduced due to various adverse events, yet the safety and efficacy of regorafenib in patients whom sorafenib has been reduced a lower dose is unclear. Furthermore, evidence is lacking on the on the safety and efficacy of regorafenib after administration of atezolizumab, bevacizumab, and lenvatinib, which are current standard first-line treatment. Hence, the aim of this study, we designed the clinical trial to evaluate the safety and efficacy of regorafenib in patients with advanced HCC who were not included in the resource trial, to establish evidence from optimized regorafenib regimen for use in current clinical practice. This slide shows the rationale of this study. For the treatment of colorectal cancer, due to concerns of adverse events, several clinical trials have been conducted to determine the optimal starting dose. We show the design of our REGAIN trial, a randomized single-center open-label phase 2 trial. We recruited unresectable HCC patients who treated at least one regimen of systemic therapy. Patient was registered to 3 arms. Arm A is after sorafenib, who can tolerate 200 mg per day. Arm B is after lenvatinib. Arm C is after atezolizumab, bevacizumab. Patients were randomly assigned to a usual dose group or dose reduction group of regorafenib to evaluate safety and efficacy of different starting doses. The primary endpoint is time to progression. Secondary endpoint of safety were incidence of AEs and discontinuation rate due to AEs. Let me move on to the result of this study. After this clinical trial began, 12 patients in each arm, 36 in total, were started on regorafenib as shown here. The target number of patients to evaluate efficacy was 192 patients, 64 patients in each arm. Taking into account the recent approval status of multiple regimens and the progress of the study, recruiting more patients was difficult. But, however, the number of patients enrolled was sufficient for safety evaluation. After discussion with the members of independent monitoring committee, this study was finally terminated with a number of patients who could be evaluated for safety. First of all, I show the background of patients included in each arm. Here are the key points of safety evaluation. Discontinuation due to adverse event within first cycle was used as a measure of safety evaluation. There was only one case of discontinuation due to AE within 1 out of 36 patients. And the rate of discontinuation due to adverse events over the whole study period was comparable to that of the resource trial. Here is the profile of the adverse events. The most frequent adverse events were similar to those in resource trial. Hand-foot skin reaction and hypertension were the most common adverse events. And the results were similar for the usual dose group and the dose reduction group. The relative dose intensity within first cycle for each dose group is shown. As can be in the result for all arms combined, the dose intensity was more likely to drop in the usual dose group, while in the dose reduction group, more patients were able to maintain the starting dose. This result was similar when broken down into each arm. Here are the Kaplan-Meier curves showing the cumulative dose modification incidence within first cycle and the full study period. It can be seen the usual dose group experiences significantly early dose modification than the dose reduction group. Effectiveness information is for reference only, as the target number of cases has not been reached. The result of summary of total 36 patients might suggest that confirmed median PFS can be expected even when used in second-line treatment. The swim approach shows the long-term efficacy over 12 months in some cases. There appears to be no clear difference between the usual dose starting group and dose reduction group. In summary, safety was confirmed for all three arms at the usual dose group and dose reduction group. Adverse event profile was similar to that of the resource trial. The usual dose group experiences significantly early dose modification than the dose reduction group. That's a conclusion. The safety of regorafenib as the second-line therapy for patients who are not included in the resource trial was verified. I'd like to thank you, my coworkers, and for excellent cooperation. Thank you for your attention.
Thank you so much. Your beautiful presentation. The paper is now open to discussion. Please.
Thank you very much for interesting presentation. I'm Hideki Iwamoto from Kurume University. Then I think Chiba University presented two prospective study about the first is about the regorafenib you presented, and the previous one was ramucirumab. So as a second line or third line, I guess. Then so both drugs seems to be acceptable in the efficacy and the safety. So which drug do you recommend as second line or third line from these results?
Thank you for an important question. We have not clear answer, but we discuss the conference in each patient. So adverse events, the pre-treatment, such as proteinuria and hypertension. And we could choose the regimen for secondary treatment, and we couldn't show the effectiveness data of regorafenib, so we couldn't clear answer. So we should show the real-world data for the after time.
Yeah, thank you very much.
Thank you. Professor Tamundi.
Yes. Okay. Thank you for chairperson. So next paper going to be presented by Professor.
Sorry. Professor.
Oh, you mean the question?
Comment to the presentation.
Okay.
Yeah.
So in sorry for miscommunication. So I actually, because the number of the patient recruitment was not reached. However, in the future, do you still to continue and this already stopped, right? The study, but in real practice, do you still continue the use regorafenib for the treatment, and what dosage of regorafenib that you would recommend for real world practice?
Thank you for question. The first question, so we can't continue this trial, so assess the effectiveness because of the recruitment is difficult. So in current clinical practice, and recommend those, in my opinion, dose reduction is an important option for patients with high risk of adverse events or liver function is poor. These are our opinion.
You mean start with those reduced?
We should select the patient so it's easy to have the AAEs.
Right. And how about start with the standard dose and then reduce the dose when the side effects occurs? Because it seems that in both arms, even the number was low, but the side effect occurs quite equally in both arms. And then the reductions of the dosage, that means reduction of the levels of the drugs, and then that might reduce the effectiveness.
In some patients, we should start in dose reduction, but in such cases, after start 880 milligrams, so those escalation is important option to the treatment journey, we think.
So in your opinion, it's going to be case by case basis, right?
Yep.
Okay, thank you so much.
Thank you. 中井先生、いかがでしょうか。
Thank you, Chairman. So my question is like similar question from Professor Tondi. So if you start with a reduced dose, you talk about in colorectal cancer, sometimes dose escalation is adapted in your introduction. So how do you decide when to increase the dose in case with a reduced regimen? When do you decide to increase to the standard dose?
Thank you. Safety assessment should be done in the first cycle for 4 weeks. After confirmation of safety in first cycle, in second cycle, we should think of the dose escalation. It's my opinion.
Yeah, thank you.
Thank you. Thank you so much. Your very important presentation. Thank you.
Thank you very much.
Next presenter is Dr. Shigeo Shimose from Kurume University. His title is Efficacy of Lenvatinib Combined with Transatase for Patient with Advanced Stage HCC, a propensity score matching. Please start.
Thank you, Chairman. My name is Shigeo Shimose from Kurume University. And thank you for giving me this opportunity to present my work. So I'd like to present the title, Efficacy of Lenvatinib Combined with Transcatheter Intraarterial Therapy for Patients with Advanced Stage of HCC, a propensity score matching. We have nothing to declare for this study. So patients are frequently diagnosed at an intermediate or advanced stage, and many patients with unresectable HCC have to receive systemic therapies. Several studies have reported that sequence therapy with lenvatinib and TACE or HIKE provides a survival benefit for patients with unresectable HCC. So recently, the launch trial revealed improved clinical outcomes in patients with advanced stage HCC treated with len combined with TACE. So this study is aimed to evaluate the effect of len combined with TACE, transcatheter intraarterial therapy, and TIT in patients with advanced stage HCC after PSM. So this study is a multi-center retrospective cohort study, and 308 patients with HCC who received lenvatinib were enrolled. And then so we excluded Child-Pugh class B or A and BCL stage A or B. Finally, 115 patients were applied to PSM. And after PSM, efficacy analysis included 90 patients in len combined with TIT and 90 patients len monotherapy group. So modifier RECIST was used for tumor response, and in the indication of len combined with TIT, in cases in which a therapeutic response to len treatment was observed, and the len treatment was continued. However, and especially in intrahepatic lesion were negative negatively correlated with OS, we recommended the administration of LEN combined with TIT. And here I show the patient characteristic before PSM, and the age and RB score and macrovascular invasion showed significant difference between two groups. However, no other factors, no differences. And I show the OS between LEN combined with TIT and LEN monotherapy before PSM. Figure A shows a comparison with LEN combined with TIT and LEN monotherapy group. MST was 28.1 months in the LEN combined with TIT, and MST was 11.4 months LEN monotherapy group. And LEN combined with TIT group was significantly higher in OS compared to LEN monotherapy. And then TIT group was invited and hike and test treatment in figure B. And MST was 13.6 months in the LEN combined with hike, and MST was 23.1 months in the LEN combined with test group. And there are no significant difference between two groups. However, these groups were significantly higher in OS compared to LEN monotherapy group. This patient characteristic after PSM, and there was no significant differences in age and RB score and the macrovascular invasion between two groups. And finally, the number test patient was 7 patient, and the high treatment was 12 patient. And the therapeutic outcome of LEN according to modified RECIST, and objective response rate and disease control rate were 47.3% and 94.7% in the LEN combined with TIT group. And the overall DCR was significantly higher compared to LEN monotherapy group. And so OS between LEN combined with TIT and LEN monotherapy after PSM. Now figure showed a comparison LEN combined with TIT and LEN monotherapy. And the MST was 23.1 months in LEN combined with TIT, and the MST was 11.6 months in the LEN monotherapy group. And so LEN combined with TIT group was higher in OS compared to LEN monotherapy. And so MST was 30.2 months in the LEN combined with hike, and MST was 12 months then combined with TEST. And there was no significant differences between two groups. However, so these groups was significantly higher in OS compared to LEN monotherapy group. And here I show a swimmer plot analysis in patients treated with LEN combined with TIT after PSM. Horizontal line is treatment duration of LEN, and gray line represented with macrovascular invasion, and blue line represented patient with an extrahepatic metastasis. And the point of yellow, the point in yellow square is a test, and the point in a red square is a hike. And you can see an patient with a macrovascular invasion is more often treated hike. However, so extrahepatic metastasis patient is added on more test. And multivariative analysis associated with OS after PSM, then combined with the TIT and the low AFP group were independent project factor for OS. And so here, and so treatment duration of LEN with or without TIT after PSM. The treatment duration in the LEN combined with TIT was 14 months, and the LEN monotherapy group was 4.4 months. And the LEN combined with TIT group was significantly higher in treatment duration compared to LEN monotherapy. And here I show the decision tree analysis for LEN combined with TIT. The rate of 12.6.1 months is in the old patient LEN combined with TIT. And the first split age was selected, And over the age 75 years, was the rate of brain combined TIT was only 0.3%. However, so less than the 75 years and 37.5%. And among them, so Malawi grade 1, the rate of brain combined with the TIT was 50%. So I think the suitable for the brain combined with TIT and less than age 75 years and Malawi grade 1. Limitation, first, this is a retrospective study, and second, the selection bias of between two groups, and third, and added on demand TIT was made of attending physicians. The conclusion, REN combined TIT improved prognosis compared to REN monotherapy in patients with advanced stage HCC. The intervention with the REN combined TIT is recommended for population age less than 75 years and with a Malawi grade 1. Thank you for your attention.
Thank you so much. Your nice presentation. So this paper is open to discussion. So Dr. Noso, please.
I'm also Ogam City Hospitals. I want to know the difference between the patient who received HIC and TACE. You said you're using the word TIT. It's quite different. It's quite strange.
Thank you for question. In this study, the high treatment include the indication, for example, multiple HCC and macrovascular invasion. Is that indication of high, but
did you see any difference between the patients, the HIC patients and TACE patients? Overall survival. I think your data is HIC is better than TACE. Is that correct?
Oh, yeah.
It's very strange for me.
Thank you. I see. And so I think the combination of REN and HIC is the dose of REN is half in the HIC treatment patient, and added HIC treatment once 3 weeks, and so combination, and so I think that causes treatment duration is longer, and compared to TACE, REN combined with TACE.
Could you please explain the regimens of HIC? Are you using UFP or something?
Yeah.
I see.
Omar, I think if you look back, Tawandi, how are you?
Hi. Go ahead, please. Professor Omada.
Nakai-sensei, konnichiwa. If you look back the history of the Kurume University and treatment, you remember the Dr. Itano?
Yeah.
Yes. So maybe you have some tricks in the Kurume University because you have a long history on the treatment, especially about the HIC. That's, to my knowledge, as far as I remember, 20 years back. That's right. So that's maybe a key issue. So how do you actually do in different ways from other institutes about the HIC procedures?
Yeah, thank you for the question. So we use a regimen of new FP, and so this regimen is so injection of lipiodol cisplatin and emergent lipiodol suspension injection, one shot, and so 5 continuous injection 5 FU for 5 days, and 5 days using a pumping system, and so the treatment once every 2 weeks, so that continuous.
So that's why could not be strange because we have a hard debate how to do it in a long time ago. So maybe that can be a trick. Yes. ね、そう思いますけど。鶴瓶は特別な方法でやってんじゃない？
Yeah, thank you very much. Okay, I'm sorry. I'm collaborator with.
Okay.
Thank you very much. It is great honor that Professor Omata told about our university. Thank you very much. Yes, it's about the hike treatment. It's really depending on the physician experience. So there is a lot of trick, I think. For example, when we perform the hike, we only inject the hemilobe, for example, because to maintain the liver function and to concentrate the drug into the, for example, macrovascular invasion part. So there are many clinical practice experience, I think. Thank you very much.
Thank you. Any other comment? So I'm sorry, time is limited. Thank you for your presentation. So we move to the next presentation, please.
Okay. Then the next presenter is Dr. Oikawa, who is online. His talk is about durvalumab and tremelimumab after treatment with anti-VEGF drugs. So please start your talk.
Can you show my slide? My name is Takeshi Oikawa from Iwate University. I'd like to talk. It's great honor. It's great honor for me to give a presentation for today. I'd like to discuss about the effectiveness of durvalumab plus tremelimumab for hepatocellular carcinoma after treatment with anti-VEGF drugs. I have no conflict of interest to disclosure. Currently, durvalumab plus tremelimumab treatment is a new first-line treatment that is administered in combination with immune checkpoint inhibitors for HCC. However, the effectiveness of durvalumab plus tremelimumab treatment for HCC in clinical practice is unknown. Therefore, we evaluated the efficacy and safety of durvalumab and tremelimumab treatment for unresectable HCC in our clinical practice. This slide shows a study of these methods. This study population included 10 patients who received durvalumab plus tremelimumab treatment and completed follow-up in our hospital between April and October 2023. We evaluated patient profiles, clinical best response according to RECIST 1.1, overall survival, progression-free survival, and adverse events according to CTCAE version 5.0. This slide shows patients' characteristics. The patient in this study received durvalumab and tremelimumab treatment. 70 patients of this study received durvalumab and tremelimumab treatment as later line systemic treatment. And also 50 patients in this trial, this study has already received for previous systemic therapy, atezolizumab plus bevacizumab. This slide shows best response. In overall, objective response rate was 10% and disease control rate was 20%. In first line, objective response rate was 0% and disease control rate was 33.3%. In the later line, objective response rate and disease control rate were 14.2% Next slide shows overall survival. The median overall survival was not reached. Next slide shows progression-free survival. In overall, the median progression-free survival was 1.95 months. In first line, the median PFS was 1.84 months. And in later line, the median PFS was 2.07 months. This slide shows adverse events. Diarrhea and dermatitis was frequently observed, and we experienced a case of diarrhea as severe adverse events. This slide shows changes in the liver function. In LB score, it is no statistically significant differences between before and after durvalumab and plus tremelimumab treatment. This slide shows a case of responder. The patient was 69-year-old woman who had multiple lung tumors, relapsed after surgery for intrahepatic lesions. She received durvalumab and tremelimumab treatment as post-line systemic treatment. So after 2 months, patient multiple lung tumors shows partial response. I'd like to present a case, IRA colitis. The patient was 60-year-old man. On third day after receiving durvalumab plus tremelimumab treatment, he had diarrhea more than 15 times, bowel movements, and so colonoscopy was performed to obtain apoptosis body and cryptitis for pathological findings to diagnose IR colitis. So patient condition improved after high-dose prednisolone. This is our conclusions. The effectiveness of durvalumab and plus tremelimumab treatment for HCC in clinical practice was lower than that reported in the Himalaya trial. However, the treatment was found to be effective for one patient who received anti-VEGF treatment, which included atezolizumab plus bevacizumab treatment. It is very important to pay attention to specific IRAs, especially diarrhea, which differ from the AEs that typically occur in occasion with the systemic treatments in patients undergoing treatment for HCC. That's all I want to say. Thank you for your attention.
Thank you, Dr. Oikawa, for your nice presentation. This paper is now open for discussion. Are there any comments or questions from audience? So, Oikawa-sensei, you mentioned the effectiveness was lower than that of Himalaya trial. Do you have any comments or reasons for the discrepancy?
Thank you for your nice, that is important point. Unfortunately, my study, tumor response was lower than Himalaya trial. I think this study was some limitations. So first, the number of patients is very small, especially first-line treatment. Previous studies reported first immune checkpoint inhibitor as first-line treatment is more effective than later line treatment. So, second, this is a single study, as a single center study. So we have to evaluate more a lot of patients and multi-center study.
Okay, thank you.
Yes, please. May I? Yes, Omata.
Thank you.
Yes, this is very small numbers, but maybe, but maybe significant because yesterday George Rao gave a wonderful lecture about, he's one of the co-authors of these papers. And he mentioned when you sub-analysis, if you analyze HB positive patients responding very well for this. So Chinese patients, B positive included. Therefore, the Himalaya study, original ones, may favor for this B virus, but we don't have many in our country. So maybe that can be a possibility, but still it's small, so it's very difficult to conclude.
Thank you for your advice. Thank you.
It's very interesting. So are there any comments or questions?
And during the treatment, was there any dose interruption or modification for these 10 patients?
No, no modifications.
Okay, thank you.
Okay. Then, okay, thank you, Dr. Oikawa.
Thank you.
So let's move on to the next presenter. Next presenter is Dr. Kaoru Tsuchiya from Musashi Red Cross Hospital. Her talk is about durvalumab plus tremelimumab for unresectable HCC. So please start.
Good morning again. So please start. So my presentation is the same as the Dr. Oikawa, and we Japanese use the steroid regimen not only as the first line, but also the second or third later line. So the aim of the study is to review the efficacy and safety of the steroid regimen in patients with unresectable HCC in real-world practice, especially to investigate the difference in efficacy and safety according to the MTT experience, because the Himalaya study only included a patient who didn't have systemic therapy, only first-line patient, but in real-world practice, we have to use the steroid regimen for the patient on the second line or later line. The method, 21 patients who received the steroid regimen at the Musashi Red Cross Hospital between April and September this year were included. A tumor assessment using the RECIST and adverse event were evaluated according to the CTCAE version 5. So you can see the baseline characteristics. The median age was 75, and 62% of the patients were modified to be patient. And 81% of the patient was BCLC. So most of the patients were very advanced stage, and 57% of the patient had extrahepatic metastasis. And this is very important. The first line patient was only one patient, and the 24% of the patient was fifth line patient. We performed the steroid regimen also in the later line patient. It's a response to outcome in the Himalaya study. So according to the result, ORR was 20%, and DCR was 60% in the first line patient in the phase 3 trial. So it's a radical response at our institute. The patient number was 19. In all patients, ORR was 15%, and DCR was 47%. However, if we focus on the MTT experience, the patient first line to third line patient, the patient number is only 9. The ORR was 22% and DCR was 66%. And first or later line patient, the patient number was only 10 and ORR was 10% and DCR was 30%. So I showed one case. The patient received sterilizer as first line. The patient had multiple intrahepatic lesion, and the patient had red color sign plus varices, and we decided to start sterilizer as first line. So it's tumor markers changes and AFP and PPK2. And the patient showed a PR analysis criteria. He continued durvalumab, the sterilization. The adverse events, compared to the sterilization in our practice, we experienced a much more adverse event, especially diarrhea or appetite loss and fatigue. So we experienced grade 3 immune-mediated adverse event. That patient number was 8. All patients were hospitalized urgently. The most common grade 3 adverse events were colitis, and among five patients, the 3 patients were steroid refractory, and we had to start infliximab. But fortunately, all patients recovered the steroid or infliximab therapy. And time to IMA was, I think, very important in real world practice. And all grade 3 adverse events were occurred within 1 month. So I showed one case, and 70s male, and it's a severe patient, and the sterilization for a second line. The first line is lenvatinib and 4.5 years, and so he was refractory to the steroid, and we started infliximab. So fortunately, he showed a PR, and it's just changes over the tumor markers. So it's very important, also important, the subsequent therapies. It's a result of the subsequent therapies in the Himalaya study. So according to the result of the Himalaya study, 40 patients could receive any subsequent second-line therapy after the sterilization. So in the real-world practice, we performed sterilization in 21 patients, and 4 patients continued the durvalumab. And as you can see, we can start any other TKIs after the sterilization. Almost 40% of the patient could receive subsequent therapy after the sterilization. So BSC patient, most of the BSC patient are later line patient. So I showed a case at the 60 male, and he started sorafenib for the peritoneal metastasis after ablation therapy. So we performed the sequence therapy, and we started the sterilization. So the sterilization showed the best response for stable disease, and after progression, we restarted lenvatinib, and AFP decreased. He continues lenvatinib therapy. In conclusion, the patient who received sterilization at first to third line therapy at our hospital showed similar radical response compared to the Himalaya study. So management of immune-mediated adverse events are most important during the sterilization. Thank you for your attention.
Thank you, Dr. Tsuchiya, for your nice presentation. Matsu-sensei.
Yes, in the following the previous study, how's the PFS for these patients? You didn't show that.
Thank you for the question. So almost 2.3 months. It's
No difference from the original Himalaya
yeah, the
study?
Himalaya study.
Okay,
Yeah.
all right.
Are there any other comments or questions? So, in some cases, as you mentioned, severe IRAE happens in this STRAT regimen. So, do you have any special tactics to find such severe adverse events in your institution?
So we don't have the special tactics, but we have an IRA team, and so we try to explain the IMA before starting the therapy to the patient and the families, and obtain the informed consent. Yeah, I think it's important.
Yeah. So, are there any, so, Dr. Tamandi, do you have any comments?
Hello.
Hi, very nice study. I think we all know that since the drug just recently approved, and then I think in every center we do not have that many patients included, but it is at least shown that it's going to be an alternative treatment for unresectable HCC. However, it seems that the diarrhea is going to be the problems for most of us, right?
Yeah. It's miserable. We had to work so hard, and yeah, yeah, but yeah, we have to. Yeah.
May I? Yes. About this IRAE, we present the data in this meeting that about 700 cases for not just GI, liver, but also including pulmonary. And then in general, I think the IRA in the GI tracts cancers is not as common as other pulmonary ones. So if you compare this one, atezolizumab, and then any difference so far you notice in terms of the occurrence frequency of the IRAE, because generally it's small numbers for the liver malignancies.
Thank you for the important question. We never experienced grade 3 diarrhea during atezolizumab plus bevacizumab. It's the first time for us to experience grade 3 diarrhea.
Okay.
So
you saw the difference?
Yeah, and
even at this moment?
Yeah.
Okay, thank you.
Okay, 中井先生何かありますか?
Yes, thank you, Professor Otsuka. So you showed us in the later line, the clinical outcomes are not so good. And given the higher incidence of IMAE, do you think still we should introduce this treatment for later line at this moment?
Thank you for the difficult question. But some patients reviewed the excellent outcome. The patient with macrovascular invasion through the partial response, and I don't know, so we have to use the steroid regimen as first line, but the HC patient, we can use 8 regimen for the patient with unresectable HCC. So we have to try to the steroid regimen during the treatment journey. Yeah.
Okay, so thank you, Dr. Tsuchiya, for your nice presentation. So we are a little bit behind the schedule, so this session should be closed. Thank you very much.
Thank you very much, chairs and lecturers.